I usually present it to my patients with, you have symptoms, it's affecting your quality of life. We definitely need to have some interventions. Here's the many of options that you have, and we make a shared decision. We make it together, taking into account your fears, your family history, your personal history, etc.
Welcome to Baptist Health Talk, a podcast on all things healthcare, powered by Baptist Health South Florida, your trusted source for healthcare prevention and wellness.
Hey everyone, I'm your host, Johanna Gomez. Welcome back to a new episode of Baptist Health Talk, where we answer your most searched questions on trending topics. Today, we are talking and getting real about perimenopause and menopause, breaking down what's actually happening in your body, what's normal, what's not, and clearing up some of the biggest misconceptions out there. We're joined by Dr. Emily Quintero, primary care physician at Baptist Health, and Dr. Ingrid Paredes, obstetrician, gynecologist. Ladies, thank you both for being here. I mean, this is a hot topic, and I think we can go hours and hours talking about not only our own personal experiences, but experiences of patients that you guys see every day asking questions. So let's start off with the basics. Explain to us what perimenopause and menopause are, because as much as they're the same family, they're different, correct?
Yes, they're family. And thank you so much for putting this together. I mean, I know it's hard for us to get out of the office, but this is very much needed. So thank you. And it will be my pleasure to explain the difference. And I love the basic terms because I feel like that's what the patients need sometimes, just to understand and go back just down to the basic terminology. So let's start with perimenopause. And I like to start with that because guess what? That comes first.
Right.
And like the word says, perimenopause is around menopause. So is that period before menopause? But wait, how do we know? Well, then let's go back. Menopause is defined in my textbooks, no period for more than 1 year.
Okay.
After the women have their last menstrual period and she doesn't bleed again for 1 year, that's menopause. What's the average age in the United States? 51 years old.
Okay.
So then
you start seeing that your period pauses?
Correct. Your period stop is your last period. It went on for a whole year, not bleeding. That's it. And I usually tell my patients to mark that last menstrual period. Now, let's go back. 10 years before that last menstrual period, 10 years before, it's perimenopause.
So we're in it.
Yes, we are. Now you're saying our age.
Yeah. I just revealed it to everyone. I'm in it. Okay. I'm in it.
I just turned 40 this year. I'm going to turn, that's a big milestone. So, and that's why the passion too for us as professional, because, and as women, it's really nice when you go through it, you get it. Or you're going to go through it, so you get it. So that's the basic terminology. Menopause, a whole year without a period. If you ever bleed, I usually tell my patients, you need to let me know, because then that's postmenopausal bleeding, which we need to investigate it. If you bleed after a whole year of not bleeding, we need to investigate. Don't assume it's normal. So 1 year no period is menopause. Any postmenopausal bleeding is cancer until proven otherwise. That's what I tell my patients. So 10 years before that is perimenopause. Because the average age is 51, we cannot say that perimenopause starts at 41, because sometimes the last period is at the age of 49, which means that 39.
Or it could happen younger.
Absolutely. That's what I mean. We're jumping now into the 30s. So that perimenopause is that period of 10 years before that last menstrual period. And your symptoms, well, I don't want to get ahead, but that's the basic definition.
Those are the basic definitions. Is there any way that maybe these symptoms can be something else, any other health conditions? Do they mimic something else?
Yes, absolutely. And that's why we have to work as a team. You know, as a primary care physician, I get patients all the time and come tell me, doctor, I'm having hot flashes and night sweats.
Yeah.
They told me I'm in menopause. But in reality, how do we know that for sure? We have to investigate other causes. Other conditions can present with similar symptoms, whether it's thyroid disorders. We see patients with hyperthyroidism. In fact, Dr. Paredes brought me a patient and I ended up working her up, and she had a thyroid problem that was causing her symptoms. We also see patients with infections. Obviously, tuberculosis is not that common, but that can cause hot flashes, night sweats. What else? We have mood disorders, patients coming in with anxiety, depression, bipolar disorder that can present with similar symptoms. Tumors, not necessarily cancer, right? Not all of them are cancer, but there's some conditions such as pheochromocytomas, carcinoid syndromes that we might end up missing because doctors say, oh, that's your menopause, for sure.
I've heard a lot of times too, they say, oh, it's just perimenopause or menopause. There's absolutely nothing that you can do about it. Like if you start feeling anxious. Is that true?
No, that's definitely not true.
Okay.
And that's why we start off by ruling everything else out, right?
Right.
Because if there's a cause of why you're having the menopause symptoms, we need to address that exact case. But this is the beauty of medicine and technology. Every day, we're coming out with new medications to be able to help our patients feel better. For example, we were just talking about this earlier. We have a lot of natural remedies over the counters, like black cohosh, something natural, right? Because if patients have mild symptoms, we don't go straight to what we use for severe symptoms, like HRT, hormone replacement therapy.
Yeah, which we'll get into in just a minute.
Yes.
The conversation has obviously shifted throughout the years. I remember a couple of years ago, no one was really talking about this. It was, I don't want to say it was taboo, but it was just something that was private. Now, everywhere you go, it is something that so many women are talking about. All age range. It just doesn't have to be women in their 40s or in their 50s or 60s. Everyone is talking about it. How excited does this get both of you to see that there has been a shift? And what's one thing that you want women to really know as we're having these conversations? I'll start with you.
Yes, I love this question because, yes, I have definitely seen the trend or the movement or the shift. I love it that we have so much information out there, but that could be a double-edged sword, right? Too much can be challenging to you. I love and I appreciate the knowledge, but it could be challenging. Just to go back to the idea of the presentation, you get the patients that have taken them 5 specialists to determine that it was menopause and perimenopause. But then you also get the ones that they are convinced that it's perimenopause or menopause, but they have a medical condition. So I'm so glad that there's more primary care physicians involved with the menopause and perimenopause because it helps the patient at the end, and that's what matters. So as a provider, this idea of perimenopause and menopause and the knowledge, I appreciate it. I encourage the patients to go see your gyno every year and your primary every year.
Yeah.
Absolutely.
Is there anything you want to add to that?
Same thing as Dr. Paredes mentions. It's important to make sure that we work as a team, right? And yes, you can have menopause, perimenopause symptoms as early as late 30s. Everyone is different. That's why we have to tackle everything case by case because we're all different human beings and we experience symptoms differently. So we have to listen to the patient. If they're telling us something is wrong, then it's our duty to just investigate and we go from there.
Okay, so let's...
And sometimes not saying it too, because I find that some providers don't have the knowledge or the expertise. And they don't want to dive into it.
Oh, gotcha.
And
so
that's,
maybe going to the right person
silence.
is
correct.
It.
And that's why it used to be a taboo. It used to be people wouldn't talk about it because guess what? We weren't trained on it.
Right.
Yeah. That's the problem. I don't blame the patients. It's us as provider. I'm a new generation. I've been out of practice for 13 years. And I was trained not to give hormones.
Right. And now that's a big talk. So let's break down some of the myths so we can get into the hormone replacement therapy that so many women are talking about. So we already debunked the fact that it doesn't matter your age, right? Perimenopause can start when you're in your 40s, but in your 30s too,
in your 30s
on the last period. So that's the number one myth that we should always talk about. Then there's another one that it only lasts a year, perimenopause. Is that true?
I wish.
No, that's definitely a myth.
Okay.
Yeah,
so how long should we think that we're going to live with all these symptoms that are just awful?
So like she mentioned earlier, perimenopause is just a window period. Yes. It's the start of when we're seeing patients have a change in their menstrual cycles. Right. It's the menopausal transition, we could put it that way.
Right.
And then it ends after the first period when it's been already a year, the cessation of menses. So in reality, patients can experience perimenopause symptoms for 3 years, 6 years, 7 years. It all depends.
I think the challenge is mainly how do you recognize that it's perimenopause? Because it can come very subtle. It's not going to come in the textbook. Hot flashes, mood changes, vaginal dryness, weight gain. Did I mention many of them? I'm sorry. But that's it. That's how they come in. But they don't always come like that.
Yeah.
For example,
and by the way, they don't always affect you the same way.
No, correct. And that's a good point because I don't want to put it out there. Oh my God, these doctors, all they want to do is treat you and give hormones.
Absolutely.
No, if it doesn't affect your quality of life, you don't have to necessarily intervene. And you don't have to have all of the symptoms. Subtle changes that I tell my patients to be aware. So you recognize, me, myself, I could tell you my mood changes. I go from 0 to 180 so quickly.
How are you feeling now?
I'm good. I'm enjoying now. This is a good thing. Now ask me at 3 a.m. when they call me for a delivery. I may not be.
Or ask her husband.
My husband who's a surgeon. So subtle changes, frozen shoulder, eczema, odor changes. My patients tell me that, Doctora, after we did the hormones, like the odor changed. Wow. The lack of sex drive. There's so many. I don't want to jump ahead, but those are the.
Let's talk about that. You just brought it up, and it was perfect. Sex life. There are some changes when it comes because vaginal dryness, or you're just not in the mood. What can we do to feel better if we feel that? What are some of the relief symptoms that you guys can help us? Something that you can help us to get through that.
I think first recognizing it.
Okay.
Recognize it that there are changes happening at the hormonal,
but it's kind of embarrassing to even have that conversation and to bring it up. I agree.
But then I'm talking to yourself now. I'm talking to the patient one-on-one. Forget the people around you. Just one-on-one. Recognize your body's changing. And you're going to go through the change and you're not going to go alone. I'll help you. Find a provider that helps you. But I think the first is recognizing. I think the first problem we find when there are problems is lack of awareness. So once you know there's a problem, then we can help it. We can help you fix it. So the tissue is going to change. The hormones are going to change. There's solutions. There's vaginal moisturizers. There's vaginal estrogen. Even if you have cancer, there is, things, because those are myths that also come. And unfortunately, there's patients with history of cancer or family history of cancer that are terrified of hormones.
Yeah. So let's talk about hormone therapy. It's a big topic. As a breast cancer survivor, I also went to my gynecologist and I was like, I don't want to touch the hormone.
Oh, thank you for sharing that.
Because it's terrifying to think that I would have to relive something that I already went through, fought, and I won. Right? So I feel like every day I'm winning. Why would I put myself in a position where, God forbid, something can happen? So anyone that's in my position or anyone that's just kind of a little nervous about hormone therapy, what do you have to say to us about that with perimenopause and menopause?
With hormone replacement therapy, back in the days, there was a big misconception because, there was studies that came out that they said, nobody should be on them. But we realized that they had flaws. And we have to get more comfortable getting patients to understand that sometimes when it's affecting our quality of life and the symptoms are severe, it's needed. Of course, we try to go based off guidelines. That's why we practice medicine the correct way. So if you have a patient who's younger than 60 or their symptoms has been within 10 years of having menopause, they would be good candidates if their symptoms are moderate to severe. Of course, you have contraindications. If you have a history of breast cancer, depending what type of cancers, right? If you have history of active liver disease, if you have a history of stroke, clots, heart disease, those are some things that we have to look into because we wouldn't necessarily try to find another option, a safer option.
Which would there's be non-hormonal options that I know that you're aware of.
Absolutely, non-hormonal options. Like she mentioned, if there's patients that are experiencing vaginal atrophy, regardless if they have a history of cancer, the systemic effects are very minimal.
Correct. And that's in the case of hormones. So I usually present it to my patients with, you have symptoms, it's affecting your quality of life. We definitely need to have some interventions. Here's the many of options that you have, and we make a shared decision. We make it together, taking into account your fears, your family history, your personal history, etc. But there's non-hormonal methods and hormonal methods.
Okay.
For the non-hormonal methods, there is oral medication, for example, that would target the hot flashes only. There is Viosa, Thermila, there is other that is no hormones, and you can take a pill. For the vaginal health, I think it's a big deal. I want to pause on vaginal health because it's together with the sex drive, the libido, the personal, and all that. So, and I think it's an effect that it starts with the lack of moisture, lack of estrogen, pain. Then you associate psychologically pain with sex. Forget it. That's it. I'll close my leg. So vaginal moisturizer, non-hormonal, maintenance, forever. Every time you had sex, definitely a lubricant. And you will be surprised how many times the patient don't understand the difference. Vaginal moisturizer is maintenance. Vaginal lubrication is the action.
It's the action. It's when you need it.
That's very important. And let me tell you, using lubrication doesn't mean that you're old, because I get that look on my patients. Doctora, I've never needed the lubrication. Yo no soy vieja. Like, don't be giving me lubrication. So I encourage that from early on all of my patients that are sexually active. I said, I'm not saying you need it. I'm saying, why not? You don't want to create the irritation. And let me tell you, sometimes forget menopause and perimenopause, but symptoms of a UTI, they will swear they have a UTI. They bring me the urine. We do a urine culture and it's negative. And guess what it is? It could just be irritation from the vagina. You friction enough, it's going to get irritated. And if it's not moist, so lubrication for everybody.
Can we just normalize the fact that if men were having this conversation about that, this would be so normal, right? And we wouldn't be a little shy to have it. But us women are just a little timid about talking about this. And I think that's where we need to normalize
yes,
this.
please.
Because I think we've normalized this, the hot flashes. Oof, you feel them every now and then, right? Because it's like something in the inside coming out.
You cannot hide it.
And you can't hide it because...
And you can see it.
You start sweating.
And you see it. I have a fan. I'm going to say this, okay? I'm not very proud of it, but it is what it is. I have a fan on my nightstand, and sometimes I just have to fan myself because it's needed. The hormone therapies really help with that.
Yes,
how about
it does.
the non-hormones? Can that help with the hot flashes? I think it's just so uncomfortable for everyone.
Absolutely. Like we were talking about Viosa, simple medication. I've used it in several patients and we never had to advance to hormonal therapy because they said, wow, doctora, my life changed with just one simple medication. That's why we keep doing research, investigating what's good for our patients. Right. And natural remedies. At least in my Hispanic culture, we always try some natural things and it may work. Whether it's teas, black cohosh, over-the-counter things, it works.
Exercise. I find that my patients, the ones that exercise, have less likely to have hot flashes. And let me tell you, exercise, muscle building, mass, like that's a big deal. And I believe that now it's being correlated with longevity. Okay. Yes. Like your muscle mass and your lifestyle, like the vision that we have elderly is like walker.
Yeah, but that's not, that doesn't have to be us.
We need to change it.
Yeah. Right.
We're going to change it. The movement.
The movement. We have to start with the movement. How about what we eat? Diet. Does it affect hot flashes? How you feel mood swings?
So I was a nutrition major, and my professor always said,
"This is you. Take it.
Avoid the whites, inflammatory, pasta, bread, rice,
everything we love.
Everything we love here in Miami, right? The Latino community.
Yeah.
But yes, we have to try to change our diet, incorporate more antioxidants, right? Fruits, veggies. You can do protein, but everything is about a well-balanced diet, not limiting yourself, but just trying to eat as healthy as you can. And then, of course, exercise, release endorphins. Yeah. Try getting that active lifestyle. So when you do hit, perimenopause, menopause, you're prepared,
Absolutely. I couldn't agree more.
You're prepared to go to war with what's ahead of you.
It's not the end of an era. It's a new beginning.
It's just a new beginning. You're right. But with this new beginning, sometimes anxiety comes with it. And sometimes you never dealt with anxiety. And then all of a sudden you're dealing with anxiety. And now it's linked to perimenopause. What do you guys know about this? What can you tell us to help us just kind of low our anxiety and slow it down just a little bit?
Such a good point. And I'm so glad you brought it because that's exactly how I had a patient last week present, not with a typical presentation. And that's why I feel like we play detective because and I need to be careful not to be all geared into perimenopause, menopause and not miss something that it could be medical. But that's her main issue. The anxiety and the depression. That's how she presented. And she had seen a psychiatrist, which I always respect the specialties. And I always get that collaboration because we need it.
Correct.
Now, if the medication is not quite doing it on its own, is making it better, I have no problem. And there's no contraindication adding that estrogen patch.
So you think the estrogen has something to do, the lack of, has something to do with the anxiety?
I think so. And here's why. There's estrogen receptors everywhere in the body. And just with that mentality, I could explain why the lack of estrogen that you go through when you're in this process of perimenopause and menopause, because that process is your ovaries being like, I'm done. And that's the biggest change. Your estrogen levels go down.
Okay.
Okay.
So should we go get blood work?
And that's a very good question.
Because I don't know. How am I going to know what my levels are?
That's a very good question. You're hitting definitely like the high yield topics because I personally, this is how I practice. I don't go based on numbers.
Oh.
Here's why.
Why?
Because I feel like for many years, the patients have been dismissed because their blood work is normal. And then what?
And
then
by the
you're
way,
crazy.
it changes, right? Like 1 year, you could have a different
1 year
blood
changes
level
and
than
next
the
month
other.
it changes.
Yes.
Your hormones change constantly.
Okay.
So by doing a blood work is a snap picture and it's not the big picture. To me, the big picture, it's your symptoms. I believe you. I know they say patients lie, but I believe my patients.
Well, it's not a lie. We just maybe exaggerate a little bit.
But you're having something that is affecting your quality of life.
Yeah,
and then, why not try it? So obviously I do the blood work. I don't say no to the blood work. But I don't let that guide me or determine if I'm going to do interventions or not. And I think that's the main distinction that I wanted to put out there. I do blood work, of course. I do check estrogen, FSH, LH, progesterone, testosterone. But you'll be surprised how many times, especially in your, 45 years old or even 39, you're having the symptoms. I do the blood work. And guess what? It's normal. Then what? What do I do? Don't
that
treat you?
shouldn't be a reason to say,
Exactly.
hey, it's not your perimenopause or your menopause.
Correct. So I have no problem doing blood work, but not letting the normality, like if the blood work are normal and they're having symptoms of what it feels like perimenopause and menopause, there's no pain or not harmful to try hormone therapy. So I have a low threshold to try hormones.
Would you put then your patient at that moment on anxiety pills to help the anxiety, and then what happens with, is that just part of
That's a good question. I send it to her.
That's what it's not, I'm not understanding it. Because then are you overall fixing just one thing or trying to fix everything?
So that's a good question because you can always try, right? We try to put them on anxiety medications, but then if they're not getting better, you tried one, you tried two, then what is the issue here? We have to try the patch.
And history taking. When did it start? Have you always had it?
Right. There's a lot of
so like there's
When
risk
is it
factor. I always
starting?
think of it like in postpartum depression. If you had depression before you were pregnant, it's a red flag for us. So in your case, if you've never dealt with anxiety, you've never dealt with depression, there's no family history of that, and then you can tell that it started around your 40s, and there's also some dryness or there's some sort of weight gain
Or some
here,
hot flashes.
or something
And
subtle
nothing else
changes.
going on.
And nothing
that
else.
we can investigate.
I do feel comfortable doing hormones. I definitely respect the specialties. I make sure they have a primary that knows them. I send them to a psychiatrist, psychologist, because that doesn't hurt. Right. I just don't want them to feel or suffer in silence and not go look for the help if it's there.
Okay. So I've seen women talk about this. You get like this just
central obesity
little thing right here, this little pooch right here that you never had before. Is that part of perimenopause, menopause? Besides working out and not eating whites, like you guys have said, what else can we do to get rid of it?
I know. And the explanation that I give it is, in my mind, I need to justify so that I'm able to explain it to a patient. When the estrogen levels decrease, there's an increase in insulin resistance. And you correct me if I'm wrong, but that's the way I think about it. So before, you used to eat a lot and your pancreas will be like, go get it. I'll break it down for you. But now, because of the low estrogen, the increased insulin resistance, meaning you're not going to be as sensitive to, decrease that blood sugar, you start to store it more.
And why does it just go right there?
Oh,
I needed to go in other places.
It goes into the known.
So the problem is that we're losing lean body mass, and then we do tend to accumulate that fatty in adipose tissue, and that's where it tends to go in us females.
Lift weights? Is that it?
Absolutely. Lifting weights would help, right? We're building more mass. Muscle mass weighs more than fat, and you burn more calories. But the problem is that the weight gain is inevitable. It's not inevitable. It's hard. And it's not directly linked to the menopause. It's everything that comes with it. The hormonal fluctuations, okay? You have mood changes. When you're feeling very anxious and depressed, how do you find the motivation to get up and go exercise and cook healthy? And that's why we have to work together as a team.
Yes.
Yes, we don't necessarily use hormones to help lose weight, but we have medications now to help us push us through. Dietitians, we have a plan.
Thank God for you guys. We have you guys guiding us. Okay, before I let you guys go, I am curious about two things. Number one, can you get pregnant while you are going through perimenopause and menopause? That was a quick yes. Don't do it.
And you've seen it.
Yes.
Really?
Yes. I had a patient. Can I say this story? She was 47 years old. I remember her. And if she's listening to me, you know who I'm talking about. She thought she was in menopause because she didn't get a period.
How many months was she?
She was 3 months pregnant.
Oh, wow.
But she thought she was in menopause because she didn't get a period.
Right.
And I'm not making this up.
She felt all the other symptoms?
No, she didn't. She was pregnant.
Okay.
She just thought it was in menopause because she didn't get a period.
Right, because she's
lack
older.
of period
does
is
right.
pregnancy too.
So, yeah,
so
you
first
can.
rule that out.
First rule that out before you think you're
In that
perimenopause.
case, she was a little younger. So, right,
47?
47.
Yeah,
So
but
it wasn't even
yeah.
around the 50, 51.
No, but with that
Yeah, of
perimenopause
course.
is 10 years. So even at 40 in that average time.
Right.
Can
So
happen.
I know that you guys, obviously, when you have a patient come to you, you take a look at everything and you rule out a lot of things. What are some of the things that you want us as patients to kind of keep in mind when we go speak to our doctors to be aware of, that you guys are aware of when you speak to us? I'll start with you.
So pretty much, you make a good point. We have to be honest with each other, right? And not be timid, because we want to get the full story and figure out what I can do for you and how we as a team can create goals to accomplish them. We need to know what's going on. So obviously starting off by getting a full history, checking the medications, seeing what else has been going on in the family, because that affects it, and then setting goals. So what are the things that you want me to help you with so we can work as a team? And then going from there, because there's so many things that we can do. We don't have to give up and just voice their opinion. Find a doctor that you trust, that you can have that relationship with, and then creating a plan.
I love what you said. Don't be shy. Don't be timid about it. Let's have these conversations, as uncomfortable as it can feel. Just do it, because you guys have probably heard it all, right?
Yes. Well, not all. I'm sure you can hear, but we've heard a lot. And I feel like that's my new saying, don't suffer in silence. And unfortunately, there have been a lot of women suffering in silence from many different aspects in the life. And whoever follows me can hear that over and over, because I say it all the time, but I don't feel like I say it enough. And there's a lot of women right now suffering in silence due to lack of sex drive, and they're embarrassed to say it. You said it. Like sometimes they don't want to talk about it. Suffering all these symptoms. I've had patients tell me, you saved my marriage, because it affects everything. Life gets in the way. Not only, the menopause, but life.
Everything.
Like I'm in it right now. I have 3 kids, and I think of like, how do I put exercise in my routine? Like, how could I fix it? You know what? And my patient told me the other day, it's you, doctora. You think about you. And it's true. Besides being doctors, we're moms, and we're taking care of everybody. Yeah. We need to take care of ourselves. Yeah. Isn't that what they tell you in the plane? Help yourself before you
help someone else. Well, I'm glad you guys are in our corner, guiding us all the way through. You really are inspirational. It was a great conversation. Thank you for sharing your insights, your expertise. And remember, viewers, be sure to hit that subscribe button on our channel here to keep up with the latest health and wellness information and tips from our experts. Thank you so much for watching. Be safe.
Find additional valuable health and wellness information on our resource blog at baptisthealth.net/news. And be sure to interact with us on our social media channels for live and upcoming events. Baptist Health Talk is brought to you by Baptist Health, the warmer side of care.